Welcome to the Human Factors and Ergonomics Hub, a series of educational podcasts that showcase the connection between human capabilities and good work design, brought to you by the Human Factors and Ergonomics Society of Australia. Hi, and welcome to the Human Factors Podcast, where today my special guests are Dr. Jon Spiro and Anthony Locke, the founders of the Nexus Human Factors Training Program in Western Australia. This program is aimed at educating the entire healthcare team, from medical and nursing through to corporate and patient support personnel. The primary focus of this course is to improve patient safety by minimising human error, promoting teamwork, and creating a culture of continuous improvement across the workplace. It's so lovely to have both of you on the podcast today. I'd like to thank you for joining us. I'm talking with Jon Spiro and Anthony Locke. Jon and Anthony, tell me a little bit about yourselves and what you do.
Yeah, so thanks, Sharon, for having us and giving us the opportunity to talk to you. As you say, I'm Jon Spiro. I'm a cardiologist at the Royal Perth Group in Western Australia, and I'm also a senior clinical lecturer at the University of Western Australia. I've had 23 years working in healthcare, and currently as a cardiologist, I contribute to the interventional cardiology program at Royal Perth Hospital. And over my training and during my early practice, I've had a strong interest in human factors. And I'm a co-founding director of the Nexus course at Royal Perth Group.
Anthony Locke, I'm an Air Force pilot and veteran of 25 years. I've worked in healthcare now for the last 7 or 8 years. I've been a director and executive director of healthcare institutions. Strong interest in human factors, as it's a life-saving practice from many examples and experiences as I've had, but also in the application of helping people be better versions of themselves day in, day out in the systems with which we operate in. I'm currently just involved in a consultancy of my own, dealing with leadership and development for executives, but also dealing with human factors and systems, processes and so forth, which is my own adventure. And it is a choose your own adventure, and I tend to like it. I
think we'd like to hear about that adventure. Do you want to tell us a bit more?
Yes, I've had the pleasure of working predominantly since I left flying for a civilian airline, and my military time is just really working across healthcare and looking at the application of human factors and also leadership development, because I see the two of them being so interwound, because one will enable the other, and just helping in those senior executives in that leadership capacity to understand what is human factors, what is the practice of HFE, how does it apply? Because I think there's we think we know something, and there's an intuitive sort of application in the understanding of human factors, but it's not until you're clearly articulated and I think our listeners will be able to maybe empathise with me on this one, is the fact that when we do explain it, we sort of get a penny drop from those senior leaders. Doesn't matter what organisation, industry we work in, that we suddenly go, this is the application of HFE and how it can be applied. So I like doing that, and I like getting involved with and helping senior leaders and CEOs of organisations.
So, Jon, how did you become interested in human factors?
Yeah, so my story is quite different to Tony's story. So I'm a UK trainee, and really I trained in cardiology at some fantastic institutions across the UK, and I would consider my training to be very, very high level and complete. And I moved to Australia to take up a consultant post. And I guess I then became acutely aware that whilst I had really significant technical proficiency, there were significant deficiencies in my training that perhaps could have been better explored and taught. In fact, in the UK, when you're a trainee, you have to attend a leadership course before you finish your qualifications. And to be honest, I just wanted to stent coronary arteries, and I didn't really want to sit in classrooms and pay money to attend courses. But nevertheless, we have to do it in the UK. And I therefore chose a course close to where I was working. And I have to say, when I attended the course, I was blown away by the content. My eyes were opened to a whole area of healthcare that really I had not appreciated. You know, we had lessons learned from failing NHS trusts, from the chief executives We had sort of safety systems education, which really had not really registered on my radar. And I guess I met Tony through a friend, and I've always had an interest in how other industries do it, in particular, both military and aviation. And of course, non-technical skills or human factors are so well entrenched in their culture and their everyday life that Tony and I got together and we had a discussion around how our two industries were different, but also had very many similarities.
So what are some of the human factors issues for you in your industries? Now, obviously, you've got two different backgrounds, but
I think from a healthcare perspective, I think the important thing to say whenever we talk about human factors and human performance in healthcare is that healthcare is an incredible profession to be part of. It every day across the country, wonderful things are happening by dedicated, compassionate people. And I think that actually, human factors is a celebration of that, as well as an analysis of when things perhaps don't go well. And I think as part of medical training, we are very much focused on curing and fixing people. And I think one of the areas that is perhaps less focused on for good reason, perhaps, is failure and identifying error, mistakes, trying to pick up errors and threats and hazards at an early stage and trying to be proactive around preventing them. And certainly when Tony and I first caught up and met actually in the pub, and like most good plans were put together over a pint of beer, what we realized was that we were both talking the same language and we were both talking from the same, we were talking the same purpose, but from two completely different industries, one that had to learn the hard way and learn their lessons and impregnate this into their culture and their practice, and the other an industry that could focus more on training and bringing that training at an earlier stage to people within healthcare.
So I believe that you've set up a Nexus course. Tell me about that.
Okay, so Nexus is really the joining of two entities insofar as the definition of the name, but what we really wanted to do was learn what was currently happening in an industry in healthcare and its infancy and its knowledge around human factors as a broad brush and a comparison coming from myself, military aviation and civilian aviation, and what is written in legislation. And what is it that healthcare professionals are telling us is missing, and what it is that other industries are doing, not just, I guess, aviation and military aviation, but what is it that these high-performing teams can actually bring to that healthcare institutions and those coal-face teams, if you like, in order to have better patient outcomes, better experiences, higher reliable systems, improved processes, and generally feeling pretty good about turning up to work and enjoying the job. I think there was room, and there's been spits and spats of human factors training and an understanding of throughout healthcare, and a lot of it sort of come from North America and Europe. And I've worked with some teams in the UK and more recently up through North America, and they share a very similar sort of story around about bringing the learnings from other industries to healthcare, and that's what Nexus is around. It's predominantly an aviation-based learning process using adult learning theory from other industries to really allow people to investigate and delve into what are human factors, what is the practice of HFE, and how would that apply to my everyday. There are some areas within healthcare that do it really, really well, but as a broad brush approach across the entire, if we just choose a hospital and one that we're familiar with here in Western Australia, was 4,500 staff. The term human factors doesn't roll off the tongue. There's a real lack of understanding. So what we wanted to do with Nexus was to bring that information and really sort of give a broad brushed overview of what it is and leave people with enough information around a number of different topic areas that they can go, okay, here's something else that I could really dive into. Here's something that can be applied to my particular work environment. And if not to improve my practice as a clinician or a non-clinician, but improve patient outcomes. And that was what we sort of came up with, was constructing a course and a training program where it's immersive in such that people get to experience it firsthand, to get that aha moment that I now understand what you're talking about. But also what we've done with Nexus is work with teams in Northern New South Wales at the University Centre for Rural Health in Lismore, Dr. Dean Robertson, Professor Charlotte Hall, and the team over there, Dr. Sue Volosky. And what we've done is work in this big conglomerate of team to figure out, what's the best approach to get this information across without another industry coming into another industry and saying, hey, this is how you should do it, because we know that that doesn't work. So we're more or less just, hey, healthcare, here's something. Would this work? How can we make it better for you?
So you touched on an important point there. What has been the best approach for you?
Oh, gee, John, I think it's been about really inviting people to be a part of it. And what we did was, before we constructed the training program, was to be a sponge, to just learn as much as we can, to use those leadership skills, to listen, to empathise, to understand, to seek. And I love this term, which is being born in human factors and ergonomy throughout many decades now. It's the difference between work imagined versus work is done. And I love that. And when I say that to chief executives and senior leaders, they're like, what's that again? And it's almost a penny drop moment for some, whereas others are like, depending on their level of and how they inflate their own ego, it may just be that, well, I know the difference. But when we've taken an approach of really seeking to understand and going, hey, here's another way of thinking, or a philosophy around the human factors approach and systems approach, do you think this would help? And they go, yeah, that could be a great tool for us to use. And okay, so, and they ask us, how would you apply that? And we're like, well, here we go. And we really get people engaged first, to the point where you could, and my previous CEO, when I was first started working in healthcare, she said to me, how do you know you succeeded in this? And I said, if I walk out the door and people's language have changed, and they notice that then they notice that I'm no longer there, that's when, they run with the concept. They believe in it. They're sipping the Kool-Aid, but they use it in application. And that's what we started to see in various different pockets around the place.
So how have you managed engagement? Is it something that you advertise and wait for people to come, or?
So I think that there's been multiple sort of lines of engagement, as it were. There's been publicity on the hospital intranet. There's been word of mouth from those who are attending. Perhaps the best advocates are those who come on the course, because Tony is a fantastic person, but he has one weakness, that he grossly undersells what he does. He's extremely adept at identifying system problems, system errors, but also finding solutions and delivering it in a way that's not only understandable, but also he has real life experience and expertise in it. And I used to joke to him by saying, you walk around the hospital with a force field around you, because if I did the same, then, a lot of other healthcare staff would see me for who I am. And I'm a clinician who doesn't have a significant degree of training and background in human factors. And that's what I wanted to change. I wanted to bring this to the hospital on a large scale. So not just for doctors and nurses, but the whole entire team. Anyone who's going to have a potential chance of coming into contact or touching a patient or influencing their journey through the hospital. So Nexus has several unique factors. One of them, of course, was Tony, who was integral in the setup of it. And I think that point is often not lost, but it's, there are very few, if any, healthcare human factor courses in the world that could have someone of Tony's pedigree in it. So I think that word of mouth is probably one of the biggest sellers. And, healthcare professions, there's always rivalry between different hospitals and different groups, and that's natural and healthy to a degree. but lots of other centres have wanted to have similar programs. They've seen the benefit. They've heard from staff who have attended it. They've seen the real change in approaches to patients. So I think to a degree, its reputation has been one of the biggest sellers.
It also helps too, Sharon, having an insightful leader and our previous executive director when we started this, Dr. Aresh Anwar, could see the value and coming from the NHS was aware of some of the programs that through aviation simulation, through British Airways and things like that, and exposing healthcare practitioners to various different elements of human factors from other industries. He saw the wealth in that, and I think to his credit, he just he saw Jon and I give an intro talk one day in cardiology, and he asked me. He said to me, "What are you doing here?" And I said, "Well, Jon asked me to turn up and just give us an introduction to what is human factors in your experience through military aviation, civilian aviation, and other applications." And then at the end of it, he said, "How much are we paying you?" And I said, "You're not paying me a thing." And he's like, "Well, what?" And he goes, "You're just doing it at your own time." I went, "Yeah." And I said, "Well, it's while I'm bored flying in the airline, I'll come and do a talk with cardiology and work with the team." And I just thought of it as a way, if I can give back to the people who give so much to the community, our healthcare workers, as we've seen throughout COVID, well, why not? Like it was a bit of a no-brainer. But having a leader that is willing to take an opportunity and run with it helps in the intrinsic or extrinsic motivation for people to change their convictions, which will lead to a behaviour change and give you the result that what you're after. So he knew that intuitively. So he's like, "I'm going to give these two jokers a run for their money and we'll do a small investment." And Jon and I ended up investing some of our own hard-earned time and money into this to get it off the ground, as we do in public health, because we're not, we're at the beck and call of the taxpayer. But he took that leap of faith, and I think that was quite courageous as a healthcare leader. And to your first question about how are you getting this? How is it getting this momentum and running? I think Jon hit the nail on the head. It really is. Once we get people in the door, because everyone said to us, you're not going to get any. I love it when people tell me I can't do something because that's just a red rag to a bull, and I'm like, okay, I'll show you. But I do it very empathetically. But I think when people told us you're never going to get anyone there unless you pay them to turn up, public healthcare is busy. And I thought, well, no, I think if people really got something out of it, and if we give, and we resonate with people and we listen to them and we take on their feedback and we give them what they want to a certain degree and take them on a journey, I think they'll turn up. And they've done that in droves. I think we've had a couple of thousand people through the course over the last sort of 3 or 4 years, and I think the word of mouth, even when I was at Coles supermarket 2 weeks ago and a lady came up to me and she goes, "You probably don't remember me," and she was fabulous. She knew my name and I unfortunately couldn't remember her name.
So she was right.
Yeah, she was right. She was right. I couldn't remember that. But she was like, "Oh, do you remember Nexus? Blah, blah, blah. You did my training and such back in 2020. And I'm like, "I'm sorry, I don't remember, but I'm glad that you remembered." And that's the key thing.
Wow. So motivation, engagement, and then I guess when you think about it, it's what's covered in the course as well. So what do you cover in it?
Yeah, so the course is basically advertised and labelled as a foundational course in human factors, and it consists of 9 modules, 3 modules per session, and the sessions are half-day sessions. So there's 3 half-day sessions, and they're done in an order because they build as participants go through the course. It starts off with an awareness, which is really trying to explain why a human factors foundational course is important and necessary in healthcare, and then talks about 2 big topics being communication and teamwork. Then the second course talks more about leadership and followership, workload management and culture, both organizational and generational culture, and brings in concepts around error management. And then finally, the third course culminates in decision making as the final module, after we have spoken about human performance and fatigue, which is particularly poorly assessed and recognized in healthcare, as well as situational awareness and automation. So the course sort of builds through those 9 modules and ultimately finishes with decision making, so that we can bring some cognitive thinking around decision making, some analytical techniques around how we make decisions. Because ultimately, the focus of the course is to improve patient safety and minimize human error by promoting teamwork, leadership, or developing leadership and encouraging leadership and improving workplace satisfaction.
The course is sort of constructed in a way that it's a broad brushed, very sort of foundational, as Jon said, to be able to take those who have a background in human factors, as we've had some people from various universities come and attend, and we've had certified practicing ergonomists attend, and we've sought their feedback on it as well. And some of the feedback we got is it's good that it can bring a novice, very much a beginner, into the world of human factors, but it can also enhance the knowledge or refresh the knowledge of those who are a practicing ergonomist.
And very much similar and synonymous with aviation, the course, the way aviation training has evolved through sort of CRM, NTS, and human factors training, our course is unique in that it pulls together a complete spread of different specialties. So we're very good in healthcare of getting into our little groups, our little silos, and training in those groups. And whilst that's often important for certain, task specific training, when we want to get into groups and actually train in real life, like we do in the hospital, for example, then we have to train as a group of including all the different specialties that we're going to find. So we have security guards there, we have people from switchboard, we have front of house, so ward clerks, clinic clerks, as well as allied health and doctors and nurses. And even executive members also are encouraged to attend, and they have attended. To their credit, they have attended. And it's those aha moments in the group, and those penny dropping moments are numerous. And when you get people all working together and training together like that.
So tell me about some of the penny dropping moments that have happened. Are you using case studies, or what are you doing?
Immersive training to tackle that auditory sort of visual kinesthetic learning that we all like to do, because we know that what we hear and what we see, and if we can teach back that retention of knowledge, that immersive sort of training package, like we'll even do a communication game or again, like even a classroom experiment around teamwork, and we get people that we talk about in one of the modules, communication. We get people to play a simple game, but then we saturate the environment with noise and distractions and so forth, and we show them how it affects their performance, which would be indicative to a busy emergency department or a theatre or a busy clinic waiting room, and noise and music playing and so forth. And we show them the direct impact of their performance based on the effects of human physiology and how they interact with their environment and the systems and their processes. And we give them a very simple process to perform. But then the penny dropping moment is when they realise that of all the errors that they made, but they didn't know, and they now have a way or something to put in their toolbox of another way of managing distractions in busy environments. Because you just got to watch the television, you can see how busy hospitals are. But so it's almost like a recognition. What we want them to do is self-recognize and be self-taught and be self-reflective, to go, oh my God, I can see myself doing that. Because going back, if I can quickly share a story, going back into my very early years as a junior pilot in the Air Force, and we used to have these magazines that would come out once a month from the safety Department of Air Force Safety, and it would be near misses or, heaven forbid, crashes or accidents that have occurred around the world in military aviation. And then the thing was how they were written and quite factual, and the voice recordings you could hear, the simulation that you could see. And then the hardest thing for me, and what really sort of drew my interest to human factors was I can see myself in their shoes. I make those same mistakes. I don't want to be a smoking hole in the ground. If I learn this stuff, and particularly when people are shooting at me, well, then I'm going to survive. That's the difference between being mediocre and technically brilliant, but I want to be that next level. And this is that next level stuff that I learned was working with special forces teams, that next level stuff that people learn as Olympic athletes. You know, they're good at what they do, but to be the best or to be better at it day in, day out, it's that understanding of the human condition and the human factors and how they interact with that system and environment. And that's what we wanted to do with the learnings throughout Nexus, was to give people having those moments where I can see myself in their shoes.
So one of the modules that we teach is communication, and communication is, of course, something that is essential in everyday life, but also something that I think most people feel that they're quite good at and probably don't need to have training in. But we know, of course, from error analysis or from just root cause analysis into when things don't go well, that there's often multiple contributing factors, but communication is always there, and it's probably the one that we're most fallible to. And I work in a cardiac catheter lab where we perform interventions on people's hearts, and we do both elective, so planned procedures, but we also do emergency procedures on patients having heart attacks, and some of them can be quite sick and need fairly time-critical treatment and can throw up a lot of problems along the way that have to be dealt with by the team around me. And I guess one of the focuses for me in teaching the communication module is having the skills and techniques practiced in the cold light of day during the planned elective cases. So when the pressure's turned on in emergency settings, the team automatically follow on with the tools and techniques that they've been given. If I can give you a brief example, so we will often administer medications, or we'll do technical procedures that require communication between two operators. And traditionally, this has sort of been an assumed communication rather than a sort of active or a sort of formalized or structured form of communication. And, it'll simply be a yes or a no sort of response from the second operator, whereas, of course, that doesn't necessarily mean that the communication package has been received and understood. So in the module that we teach the communication, we talk about some of the basic techniques of readback communication, closing the loop on that communication, but also empowering staff and the team around you to raise concerns and have a technique of doing that so that they can escalate to get the attention of the operator, who can often be very task fixated and really doesn't want to be disturbed, but needs to be. So it's empowering the team to be able to do that. And then finally, the assertive statement framework. And we've had people come through the module, and Tony has an example of a theatre nurse who came through very excited after she'd attended Nexus, where she'd used the assertive framework statement. And Tony, I don't know if you'd like to share that with us.
Yeah, she was. It was funny. We talk about assertive communication, and one of those penny dropping moments is when I say to them, "Oh, has anyone ever told you that you need to be more assertive?" And then you just think to yourself, "What does that actually mean?" Unless people have actually received any particular training in it, it's usually people understand the term assertive, but putting it into practice is another thing. And so, as Jon said, we developed the assertive statement framework, which is really, really simple, and we give people a little. We give people the Nexus book sort of thing, and they've got a little rip-out perforated card that they can put in, because people in healthcare love tangible things. But it was like she can put it in her little plastic holder in her lanyard sort of thing as a quick ready reference, because, she felt as if having that there would enable her to be assertive. And anyway, she rang me up one afternoon and she said, "Oh, that assertive statement framework thing, it works." And I'm like, "Oh, okay, tell me what happened." And she said, "We had a patient that came in for a procedure on an eye. I think it was a lens replacement, cataract. And there was the ophthalmologist, the anaesthetist, the anaesthetic tech in the room. and 2 theatre nurses, plus an orderly, if you like, or a PCA in there. And she was the scout nurse, so she was coming and going between one of the prep rooms and delivering the tools to be used and the lenses. Anyway, she noticed that they were preparing the right eye for the procedure when she spoke to the patient previously. She thought it was the left eye. And anyway, these lists run pretty fast. And she thought, oh, hang on, have I got it wrong? And she checked with one of the other team members, and she goes, no, it's the left eye. Well, they draped the right eye. And anyway, she used the assertive statement framework as the proceduralist and the anaesthetist were ready to go just before the procedure was being done. And she said, listen, she went through the assertive statement framework, and they all stopped at her. And she felt like that pause was like the longest pause ever, because she says, I'm not a very confident person and I don't like to challenge people and I just want to be loved and so forth. And I said, you're not alone there. And then the surgeon looked at me and the anaesthetist looked at me and they said, well, yeah, let's double check. And they went back through the patient consent form, they went back through the checklist and said, yes, we've got the wrong side. Now, the patient can't tell us because they're under the influence of anesthesia at the time, but when we looked at the system and the process beforehand, one of the patients actually jumped ahead of the queue. And so there was a lot of predisposition and understanding of the system processes. So mind you, there's been a lot of changes in that, but using that framework, she felt like she had a tool or a crux or something that she can rely upon, and she now uses it in a written form if she's writing emails to staff members, or she loves talking to her husband about it, she tells me. But and I think it's just another way that, for those who haven't been exposed to something like this before, it gives them a bench to start off from.
So what are some of the phrases that she could have used in that scenario?
Yeah, so in that scenario, I think the phrase is really around what we get them to do is we take them through a 4-step process of, the first thing about teamwork is what we say is you've got to know everybody's name. There's no point working in a team you don't know who's in your team. And you'd be surprised how many people work in teams in healthcare, and they just don't know people's names. And sometimes because of the equipment that they're wearing and, being in an emergency department, you just don't know unless you're familiar with the team itself. So starting off with someone's name and then understanding what it is the issue is, the problem, the challenge, the solution. And then what we usually get people to do is to formulate or hold a question within that assertive statement framework, or get them to respond, because what we find is the implicit nature of communication, where we try and raise something in a conversation within a team environment or with a colleague, and it just sort of, because of the language that we choose, it waffles off out into the ether and it never really lands anywhere because we don't get a response. But what I've learned in my early military aviation is if you're going to say something on a busy flight deck and you're cruising around at night, on night vision goggles, and someone's shooting at you, you got to make sure that your communication's heard. And how do you do that? You force the question, you force a response. And so she had forced a response from someone in the room, and in her language that she chose, she wanted the response. And she said it. Otherwise, I just would have floated around and just would have gone, hey, can we just double check that it's the right? But what she did was, she used the person's name. She stated the problem and the challenge, the issue. She offered a solution straight away. I've got the solution here for you. I'm not going to take up too much more of your time. What do you think? How do we get that response from her? And and it worked out extremely well for her and the team.
And Sharon, if I can put that into context, because that's one small drop in the ocean, really, of the sort of examples and tools that we equip people with. When I was a medical student in London years and years ago, this sort of highlighted to me, I guess, and probably looking back sowed the seed of why I'm passionate about this. I was in a theatre watching a urology procedure, which is basically where the surgeon had a scope in the patient's bladder and was planning out where the tumour was, because this was a procedure to plan future surgery. And it was fairly dull, I have to say. It was fairly boring. When I was standing with one of the nurses at the back, and then something funny happened. He put the washing jet on the camera and all the water ran up the screen. So I said to the nurse next to me, he's got the camera upside down, hasn't he? And her response to me was, oh, yeah, he often does that. But we just reverse everything that he shouts out in the notes because he doesn't like to be told that he's doing something wrong. And I have to say, I was standing up, I nearly fell over, but I thought to myself, what is wrong with these people? We're in a team here that are afraid to talk to each other. We've got a nurse who's afraid to speak up. And they've managed to establish a workaround where they just reverse everything the surgeon has shouted out because they know he's holding it upside down. And so I think looking back, that probably instilled a desire to not become like him.
Yes, that's an amazing example. So what are some of the other modules that you teach or how you teach them?
I think what we do is we build the structure of the 9 modules builds upon, and we take the learnings from one and build upon it in the next and so forth. So I think, after we do that communication module, we do an immersive teamwork exercise where we just, people have been sitting in a learning environment for a while. It's like, hey, you guys are going to teach us. Nothing worse than going to a session on teamwork and someone writes up on a whiteboard, okay, tell me all about teamwork. You just glaze over and blah. So we throw people in the deep end, and by this stage, it works well with a cup of tea or a coffee and a Tim Tam before we do this session. So people are sort of limbered up but within that teamwork module, the participants tell us what it is about their teams, what it is about that exists within healthcare teams where there are areas for improvement, what it is that they can do differently when they work in a team, what it is around the cultural aspects, what it is around, like Jon's example there of the urology procedure was workarounds, and we know that term very well in HFE, all the workarounds we have for an inadequate system or an inadequate procedure or in this case, an individual that does something different to what's expected within a standard operating procedure is, this is why I like working with leadership, because unless we give the people the chance to be able to change their interaction within the system and be able to respectfully ask questions around why we do the things we do, and using the information, as I said before, at the coalface, or at that patient-centred care, right at the point of care. If we empower those people to change the system, well, then we improve the reliability and we reduce complexity. But leadership is really important to allow teams to do that. And I think after teamwork, that's why we talk about leadership. And a term which is not really understood well is followership. And that was something that was really brought home to me in working with other military leaders around the world, is that they said to me, oh, Tony, why don't you brush a cautious subject of followership with your human factors education system? And I thought, oh, okay, cool. And then people have loved it. They've never really thought about what it is to be a good follower. And that's not the blind obedience and subservience. It's around supporting those that lead in order to ensure that we get good outcomes, or substituting for the leader. So we often see that leadership is an integral part, but then we push on into understanding a little bit around generational culture and workload, and understanding how that human physiological aspect of workload and I guess that cognitive saturation and the effects on the senses and so forth. And we would do training in Air Force around understanding the effects of auditory and sensory decline when there's cognitive saturation. And we would look at ways to recognise that throughout the workload. And I got to tell you, I often had a perception that hospitals and the healthcare system was busy. No, I had no idea. I've recently been a patient. I've had the fortunate experience of working in a 4,500 staff hospital. It's massively busy with so many intricate, complex systems, and interwound is phenomenal. And the human condition dictates this. But understanding what it is around that human condition and dealing with the cognitive saturation is really good. So we get people to recognise that and to understand the physiological aspects of it. And then we push into understanding the term situational awareness, born out of the 80s and loosely thrown around and not well understood. And there's not a lot of research out there. And I think a lot of the work that's done in aviation and, looking at some of the research that's come out of Lufthansa Airways back in the 90s and Airbus and Boeing and so forth, and how understanding what it is to gain it, to lose it, how do we form it, the aspects of time and intervention, but also how it interacts with decision-making. And then we finish with, I'll take a step back. We also look at system design very, very briefly in automation, because we see a massive uptake in automation of patient monitoring recently, like one of the hospitals here in Western Australia. We actually work with Philips and we monitor patients back in the States while everyone else is sleeping. So it combats fatigue. And before we get to situational awareness and decision-making, we often discuss the term fatigue. And boy, do we open up a can of worms when we talk about it. And we've got a lot of, in our faculty, we've got some great people who've done sleep studies who actually lean right into some of the theories proposed by Matt Walker, the famous psychologist and neuroscientist that deals with sleep and the effects of fatigue. We're leveraging off some of the own data that's being generated here in Australia and Western Australia. And understanding all these conditions and how fatigue relates to error management, as Jon said before, we just want people to make the best decisions that they can. And having good leaders to support people to do that, to be able to have psychological safety within their teams and the organisation, we can actually limit, and industries have proven that, and I'm sure our listeners will agree, that when we combine a lot of these with good systems and robust processes and the review of that, we can actually eliminate errors and improve reliability very quickly and make it because I think the thing is, if we can make it a workplace which is highly engaged and people love coming to work because of these things, I think having been in senior executive positions, I see the financial effects as well as everything from human resources and recruiting as well.
But I think you touched on a great point there, Tony, actually, because one of the modules also is around threat and error management. And that's not a concept I was familiar with until I started working with Tony and the team. And I think within healthcare, historically, there's been a very reactive approach to error and complication. And I think, things are changing, culture is changing, and there needs to be more proactivity around it. And certainly when participants come on the course, they realize that actually error reporting and, the lessons learned from near misses and other events within the hospital, it's well within their mean to stand up, to have their concerns heard and actually put mitigating steps in place to try and reduce the number of errors. I mean, errors in healthcare are an ongoing problem. We often talk about the data from the Grattan Institute, which is an independent think tank that works with government agencies, and they publish data around complications in hospital. And a recent publication quoted figures as much as 1 in 9 patients going to hospital will suffer some form of complication or error. And in fact, if you stay in that hospital overnight, it can go up to a staggering 1 in 4 patients. And these can be minor things from, small medication errors or patients not receiving letters or their appointments and other things, all the way through to significant problems like hospital-associated infection or injury, falls on the ward, or even sentinel events, things like wrong surgery on the wrong patient or the wrong prosthesis being put in the wrong patient. And so whilst human factors are often thought of as a sort of negative connotations, I think one of the aha moments for people coming on the course is that they can see the real benefit in being proactive and having a good error reporting system and a culture that accepts it. And I think that moving towards that as a group is the way to bring in sustainable change.
Given that often it's the decision makers above the individuals that are controlling some of the culture and the system within which people work, how are we better able to influence them?
I think that's the $64 million question. And I think a lot of people who practice HFE, with either in their own businesses or as a part of multinationals or throughout government agencies, is just how do we get those leaders to understand the effects and the potential of looking forward as opposed to looking behind in regarding to almost predict or make us safer or more reliable or improve system processes. Because people will tell you the world over, and psychologists and psychiatrists and people who delve in a lot more than just the human mind and the human factors, is really around, you can't continue to look back to improve what's going forward. You've got to look forward to see what is potentially there and how we can improve that. So one of the ways I've done this with leaders in healthcare is to take a proactive approach into of all the clinical incidents and events that we've had and unforeseen circumstances potentially that have occurred in the healthcare institutions where I've worked, is that instead of taking just a retrospective look, how would you apply a retrospective look that what you've just investigated over a period of 3 months into a proactive measure? What would that look like? So if you could go into a particular ward or a clinic or a practice or a busy emergency department and this happened again, how would you look at a proactive measure to prevent it even occurring in the first place? And then we get people thinking about the system within they operate and trying, as Jon said before, threat and area management, to identify the potential threats before they occur. And that's a real shift in thinking, where I would go flying on with a crew, and part of our brief before we go flying was to what are the potential threats that are going to be against us today to operate safely, to deliver the task well, to achieve a high outcome. And the threats are ourselves, our egos, our biases, the weather, the equipment, our procedures, our traffic control, and we'd sit there as part of a 15-minute brief, 30-minute brief, and we would go through the potential threats. Okay, so that's we would highlight the top 3 potential threats and what we would do, how are we going to mitigate those threats, and what are we going to do if one of those threats should pop up. And the human mind is a wonderful thing. When you visualize or you anticipate something and you react to that, when it occurs, it's almost like you've prepared for it before it actually happened. So the communication becomes easier, the understanding becomes easier, the process becomes easier. You've primed the human mind to think about this, and within a team concept, you sort of become unstoppable, which is great. And we do the same thing with leaders. So it's really hard to change that shift in thinking, but there's a lot of conversation that are happening now. And a couple of weeks ago, I had a great conversation. One of the chief executives here in the healthcare system was really around that. How do we change the thinking of leaders to be thinking about what's coming down the pipeline instead of looking over our shoulder all the time? And I said, there's a lot of smarter minds out there than me that can help you, but I'm sure we can nut it out.
I was thinking the near miss discussion that Jon just had, really talking about the near misses, is identifying some of the areas, isn't it? And verbalizing as a group what can go wrong, but on the basis of areas that have gone wrong. I'm thinking that is likely to change perception. Is that what you found?
Yeah, it was funny. I remember one day walking through the trauma ward of a hospital, and one of the senior nurses, she came up and tapped me on the shoulder. She goes, "Oh, you're that human factors bloke. I've got something to tell you." And I'm like, "Oh, okay, cool." She's a lovely lady, very, 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 very smart, an experienced nurse of many years. And she said to me, "Oh, you wouldn't believe it. We nearly sent the wrong person down to CT for the wrong body part to get scanned and have CT with contrast, blah blah blah." And yeah, but we tracked it, and yeah, we got it. We got the right person down there. And I went, well. Let me get a pen and a piece of paper. Right. How did you do this? What? Take me through the process. How did you capture this? How did you prevent this from happening? And she's like, "Oh, it was easy." Oh, okay, great. Well, are we going to share that with everybody else? So the lessons that you learned. And I think we struggle with that. It doesn't matter what industry we work in, aviation, healthcare, oil, gas, mining, that to spread that learning. And because we used to have a saying that, I don't want my colleagues to step in the same pothole that I have, or that's potentially the same pothole. And to this nurse's credit, she got up at her next departmental meeting and said, hey, this is what I sort of prevented from occurring, because this little old lady in her condition would have had an adverse experience if she had gone down and had this CT with contrast. And this is how we trapped it. So the lessons are, and to her credit, she came back to me and she said there was a complete shift in thinking around about when we just trap something, when we just in time. And I sort of penned this term that sometimes we're accidentally safe, but we don't know why. And she goes, oh, okay, well, maybe I should pay more attention to this. And I'm like, bingo.
And that's a great example, Tony, because we've heard as well on the course staff members telling us a similar sort of near miss event, or occasionally when an accident has happened on the ward, in particular patients falling over equipment, and then there'll frequently be someone else in the room who will put their hand up and sort of say, yeah, that happened to us last month. And then you start thinking, you guys work one floor below each other. Why are we not cross-pollinating the knowledge, the learnings, capturing these near misses? And, sometimes I think in healthcare, it can feel overwhelming, right? It can feel like we are a very, very small piece of the puzzle. And, we often perhaps don't have that much to contribute. And I think that when participants come through the course and they realize that actually error reporting is fundamental, and changing the culture so that it encourages people to speak up, and we move away from the historic model of blame, which has been present in hospitals and healthcare systems, which is changing, but is still unfortunately present. And we need to sort of, for the collective good, move forward with that. And I know that a lot of executive teams are working hard to change that.
I guess one of the problems is the fear of liability. So they don't want to talk about these things. But I'm wondering whether you've had like a latent error committee, or just an error committee that's specifically looking at incidents and working out ways that could be remedied.
Yeah, so the hospitals where we've been working in do have changed their safety reporting models and safety reporting networks. And certainly there's been a move kind of globally towards performing root cause analyses when adverse events occur. And of course, human factors has a strong component really throughout all of that. And I know, Tony, you were involved in some of those meetings and discussions. But I guess that's part of the puzzle. But I guess it's being able to disseminate that information onto a receptive audience who actually genuinely believe that it'll lead to change, and that it's not just a matter of going through the motions just to purely sort of box tick the event that's unfortunately occurred.
I'm going to jump on my soapbox a bit here, Sharon, because it frustrates the hell out of me that you can tell how good a safety system is by how much an organisation or industry invests in it. And I think we could invest a lot more in the safety systems we have within healthcare. And I think I've worked across hospitals in New South Wales and Western Australia and sort of health teams in Victoria and so forth. And I just think that the one thing I love about working in healthcare, they are so data rich. Like, oh my God, it is stunning the amount of data that is at people's fingertips, and the incredible smart people that work in this data analysis. And I just love to go into a hospital for 3 months, or any healthcare institution, pull this data out, look at some of the thematic analysis from low-grade incidents where, it's been, 3 Panadol instead of 2, or, a time, they didn't get it at 6 hours, I got it at 6 hours and 30 or whatever, and looked at some of those low-grade incidents, and I'll show you a direct correlation to the ones where we really nearly bring the organisation to its knees. And by understanding what happens at those everyday occurrences and the links that can be transposed across is phenomenal. And as Jon said right at the start of the conversation, is that, we are two different worlds. Like I'm predominantly military aviation and civilian aviation, and then Jon's in healthcare, but our failure points are so closely aligned. And by getting stuck into this data and doing the research, having teams of people, and I would love to have in a hospital, half a dozen HFE specialists just come in and just look at some of the systems and looking at everything from alarm fatigue to all sorts of things and human-machine interface to systems with which we operate. But that there represents, as we were talking about before, about looking forward as opposed to looking back. This is where the richness sits. And yeah, I've beaten the drum a bit, and I think some of my senior healthcare colleagues are probably a bit sick of me beating the drum a bit, but I would like to invest a lot more in human factors and ergonomics in healthcare. And I think we'd be a richer and a safer industry and lead the world in this if we could.
But Sharon, the problem here, of course, is that reporting error, reporting complications is deeply unpopular. It's necessary, of course. When Tony and I set up the course, we went to the media department in our hospital and we said, hey guys, we're the first healthcare organization in the world to have a full-time pilot who's jumped ship, and we're working together. We're going to make big inroads. We're really excited. And we told them that they were very excited. They had their pen and paper out, and we started telling them about what we were going to do, and we were going to bring in an error reporting culture. And they put their notebooks down and just said, guys, you don't have a story here. This is not a story that we're going to want to run with. And that kind of, I guess, speaks to the source of the problem. There was a publication in the British Medical Journal years ago that we show the slide, the main graphic from on the course. And it was data from the United States. And they had analyzed annual mortality. And the methodology, you can pick it apart, but nevertheless, what they attempted to do, they looked at all the deaths across America and they tried to work out how many patients had some form of medical error or complication that had contributed to their death. So they, in other words, used complication or error as a cause of death or a contributor to death. And when they put the data together, medical error came up as the third leading cause of death. Now, unfortunately, in healthcare, funding and resource tends to follow data. If you don't collect this data, it's hard to justify the expenditure and the resource. We're very resource limited, as you know. But what we say on the course is, can you imagine what hospitals would look like if, the third biggest funded area of the hospital was human factors or human performance training? It would look very, very different landscape to how it looks now.
Thanks for joining us at the Human Factors and Ergonomics Hub, brought to you by the Human Factors and Ergonomics Society of Australia, where human-centred design really matters. If you like this podcast, make us your favourite in your podcast app. We look forward to chatting with you next time.